psychologist in the Department of Psychiatry and a member of the Committee of Diversity here at the UCSF Psychiatry Department. And I'm going to introduce the lectureship, put some context to it. Dr. Evelyn Lee was an immigrant from China who received her bachelor's in social work in 1963 in Hong Kong. She obtained her master's in social work in 1968 from Case Western University, and in 1983 her doctorate in mental health administration from the University of Massachusetts at Amherst. In 1982, she joined UCSF as an assistant professor and program director in the Asian Focus Inpatient Psychiatric Unit at San Francisco General Hospital. In 1988, Evelyn Lee established the first Chinese Family Alliance of Mentally Ill and authored the Parenting Teens and Handbook, 10 Principles for Raising Chinese American Teens, which was translated and adapted into Chinese and Vietnamese. In 1992, she helped to incorporate the largest 5 healthcare organizations in Chinatown, whose first initials created the NICO's Chinese Health Coalition. She has received dozens of national and local awards and published countless of articles relating to various mental health issues, such as refugee trauma, immigrant acculturation, cultural communication, and cultural competency. Dr. Lee was widely respected and loved in the mental health field and in the Asian American community as a clinician, administrator, teacher, researcher, mentor, mental health advocate, and a humanitarian for 30 years, until her untimely death in 2003. This annual Evelyn Lee lectureship is named in her honor.
Thank you so much, Joe. I think I got this. Thank you so much. I appreciate it. And did anybody in the room know Evelyn Lee? Did anybody met her? I hadn't either, so I've been in the Department of Psychiatry for almost 10 years now, and just, she was really phenomenal. Learned from what I know, and I can think of no one better, Dr. Choo really embodies the type of provider that Evelyn would have loved to meet and work with. So I have the pleasure, my name is Christina Mandarine. For those of you who don't know me, I'm a professor and vice chair for diversity and health equity in the Department of Psychiatry. I'm thankful to members of the diversity committee, including one of our members here, Peter Uresti, who serves in the education task force, who helped select this year's Evelyn Lee speaker, who is Dr. Choo, and I'm thrilled to introduce her to you all for our roundtable discussion. For those of you who don't know Dr. Choo, she's an associate professor at the Center for Policy and Research in Emergency Medicine at OHSU. She's a practicing physician as well as an NIH-funded scientist with expertise in drug policy as well as gender inequities in healthcare. She's a founder and strategic lead for Time's Up Healthcare, which is an initiative of the Time's Up Foundation, which advocates for safety and equity in the healthcare workforce. And she's written a lot about gender and harassment in healthcare in New England Journal, JAMA, Harvard Business Review. She's widely recognized for her work in this area, and actually most recently has a column in Lancet talking about inequities or going over inequities in medicine. And as I mentioned during her grand rounds today, Dr. Choo is really one of these unique individuals who's able to synthesize and condense very complicated and uncomfortable pieces of information, like inequities in medicine, and make them very accessible, and also you leave kind of feeling inspired that you can do something to change and make a difference. So what we're gonna do today, I'm thrilled to have you here, so please help me to welcome her here. Which I should say, Esther actually worked here in San Francisco General years ago in the emergency room before.
It did not look like that.
Before it was the fancy emergency room, exactly. And so how we're going to do it, because Esther's Grand Rounds was filmed, it's available on video today, so instead of her kind of giving the talk again, what we were thinking about doing was more having a little bit of a conversation, but it's a small enough room that I think that we could have a conversation also with the room and take a lot of questions from the audience. So we can go around and do that as well. And actually, maybe I'm gonna, if you wouldn't mind, I'm gonna give this to you just as questions do come up later, not right now. So that we can have that kind of back and forth with everyone. So I'll get us started, okay? And then we can kind of open it up for some different questions. Esther's heard this before because I had a fantasy that out and about in some other places, there were these innovations that we didn't know about here at UCSF or at the ZSFG in kind of addressing inequities in healthcare. And I think that there are some, and I'd like her to talk about the ones that we talked about, but there, yeah, I guess I'd just like you to talk about some of the inequity, some of the places that are doing some really innovative work in this area so that we can maybe learn some things from those institutions.
Yeah, and I also, as I started doing this work where I go around to lots of different places and talk about things like gender bias and discrimination and sexual harassment and racial and other types of inequity, I also felt like there was some place hiding from me that had it figured out. You know, that there were centers of excellence around the country that was likely to be a broad spectrum, but there were clearly people at this end of the spectrum. And then I realized this issue in aggregate, this kind of group of issues, is so complicated and entrenched, and there are just so many different approaches to thinking about it that really nobody ever emerges as the center of excellence. But I think it's more that different organizations have taken different tacks and have decided to focus on different parts of it, you know? And just to explain sort of how I think about it and how we, meaning people who work in this field and particularly people who are members of Council of Healthcare, think about this. We think about it across a number of dimensions. So there's safety, equity, equity meaning things like pay equity and advancement equity, but also just representation in spaces in healthcare, and then dignity of work, just all those things that make you feel respected and valued. So when you think about safety, equity, and dignity of work, those already encompass a broad range of things that affect the organization. And then we think about where are you in your process of assessing your organization for being great across those domains. And I use a healthcare framework just because it's so much easier to think through it, and we're used to doing this. I think of when you're assessing a healthcare process in terms of quality and safety, you might use something like a Donaghy-Beating framework. There are many, many frameworks out there for assessing the quality of healthcare delivery, but Donaghy-Beating is one that's familiar and is used globally. And so in the Donaghy-Beating framework, you think about what are the structures in place? What are the resources, the policies, the procedures, the human resources? Who are the people who manage these problems, who handle complaints, for example, and make sure that they're sort of followed through. And then you think of the processes. Like, so how well are we implementing the policies and procedures? So we have a policy for handling stroke. Are we actually following through in a timely fashion with those policies and procedures? And if not, what happens? What are kind of our process measures and what do we do with them? And then the final area is outcomes. So do we have clearly articulated outcomes, and what is our progress in meeting those outcomes? What are the measures that we're using? Because in healthcare we measure everything. And are we sort of meeting our targets? And if not, how does that information feed back into our structures and our processes so that we have a better chance at meeting our target outcomes? And once we've accomplished those, what are the next level outcomes if we're really going for a continuous process of improvement and excellence? So I think about sort of organizations and where they are in all those things. I will say in general, organizations cluster towards having something in the structures box, but less in processes and very little in clearly articulated outcomes or progress towards outcomes, because all of that requires data collection and transparency, which we really don't have. And so I think when I go to different institutions, I'm thinking like, where are your strengths? Because everybody has strengths, And for some, it's really, they really have put a lot of emphasis on things like salary equity, or on leadership representation, or on having robust family leave policies, because that's part of bringing in a diverse and inclusive workforce. Other organizations are really focused around the culture of safety. They have a lot of work around code of conduct and communicating what the code of conduct is and having like very clear and dedicated trainings and all kinds of maintenance of education. Other places are much better at sort of dignity and like what are the interpersonal interactions. And so, and places are different in terms of being like, I have every policy known to man, and we just have the world-class policies. Everything is policied up. But then, nothing really processes or outcomes, whereas other organizations are really working to articulate, like, what do we want to see, and I would say articulate outcomes in this realm of stuff that we have a hard time talking about it because it's awkward and feels uncomfortable. There's lots of shame and fear. I could talk about all that anxious avoidance that's triggered when you mention any of these topics, but I think we're very far behind in articulating outcomes, and just putting any outcomes down on paper across these domains is so challenging. And organizations do it. I mean, UCSF has a new commitment to 50-50 representation across leadership roles. Having that clearly articulated as a goal is pretty rare. So I guess the long answer to your short question is it's rare to see a single institution that represents kind of innovation in this area across domains. But I think there are little sparks of of excellence, and what would be really great to see over time is seeing major healthcare systems and health professional schools decide, and I just need to be happy, I just need a couple across the country to decide that they really are going to have ownership of this entire space and make that their thing because they so believe that it will have a huge return of investment in everything that they care about. Including the talent they can recruit in, the productivity in terms of scholarship and clinical work, and then ultimately patient outcomes.
Right. And I'm wondering, kind of mentioning the sparks, some of the places that you said that were really great earlier today. Maybe you can tell this group a little bit about what work's being done at the University of Michigan and also the operational eminence.
Yeah, so I mentioned, we were talking about what are these great innovations that have really caught your eye, and there are these areas where clearly organizations have decided to be head and shoulders above the rest. So at the University of Michigan, they did a comprehensive assessment of sexual harassment occurring at the School of Medicine, and not just physicians, but across roles. And that actually entailed working with unions so that they could engage nurses and other staff in this data collection. The other piece of it is they used a standardized, well-validated instrument to measure, it's the SEQ, to measure the prevalence of sexual harassment. So the SEQ is probably the gold standard for measuring different types of sexual harassment. And so often, when places report, this is, kind of our culture and this is what it's like for women, they're just asking questions that, we're not designed to ask in any granular level what is going on in terms of harassment and other forms of inequity and discrimination. And so they actually deployed the survey. Their results will be out soon, and I think are pretty impressive. But we rarely do that kind of surveillance. The surveillance we do is we wait for complaints to rise to the surface, and that's what we know about. And as you know, that is like the teeny, tiniest tip of the iceberg, and we ignore the body of the iceberg. So I am saying institutions like University of Michigan are not alone, but are really trying to get the measurement piece in place, because what do we fix in healthcare without measuring it? And I think that is one big innovation where I think our institutions will I think that everybody at some point will be held to higher standards in terms of pre-symptomatic data collection in these areas. So I think that's one. Another one we talked about was Kaiser and Permanente, and how invested they have been in the visible diversity of leadership at their executive leadership level across Kaiser National. And that is very obvious. You just pull up their website and you're like, whoa, somebody's doing something on purpose here. Because this does not happen. I mean, just pull up any 10 large health systems. That does not happen by mistake. It's clearly been a very intentional thing. And so I think, that doesn't always trickle down to your culture the way you want it to, but it's a good starting place. So that was another one. There were other kind of like individual, like very almost like sometimes at the departmental level initiative. Actually, or even before that, we sort of talked about how if you do have offices for diversity, inclusion, and equity, that the way that you set those up is extremely different from institution to institution. I've been impressed by that as I go around the country. I mean, there are offices that are essentially one person with minimal admin support and a teeny tiny budget. There are places where really that office reports directly to the highest leadership in the hospital, and those efforts are integrated throughout. And so I think saying we have, it's just like all diversity efforts, saying that you have a diversity, equity, and inclusion office can be a checkbox, or it can be something meaningful that's integrated into the entire strategic vision for your institution. So I think there's lots of room for innovation and actually revision of what those offices mean across the country now that they're well-established entities in most healthcare organizations. So I think that's another thing. And then I think building concerns around safety, equity, and dignity of work into all the things that we do, so into our regular processes, rather than saying, today we're going to have a diversity day. Everybody who's interested in diversity, come to the diversity day and take part in the diversity activities. And you know, you all, I'm sure, taking part in those things. Those are great and necessary, and I think it's a good place for people who are already invested to come and have community and to network and build up. So they're absolutely necessary, but they're often not sufficient. And part of it is that the people who really need to hear those messages and be engaged simply don't come. So how do we incorporate these topics and these conversations into our day-to-day work? And being super practical, I think a good first step is just integrating these conversations into everything that we already have in place. You know, so if you have a CQI or an M&M function in your department, do an organizational M&M, or an M&M about racism, or about sexism, or about harassment, real cases that played out in the department or in the institution. Present them exactly the same way, in exactly the format. Another good format that I think is just daily rounds. So in the emergency department, in internal medicine, we have daily clinical rounds. I have friends who do things like wellness rounds, where as part of rounds I'll go around and say, what's something good that you feel that you like? I will do safety rounds. What is something that has happened to you in the clinical environment that has made you feel unsafe or not respected? Try that. It is amazing what comes out, especially if you make those interdisciplinary rounds and you incorporate all team members. You will hear things that you would be sad to not know about on your teams. And the nice thing about all those things, M&M, you know, your rounds, simulation is another one, is another great format for introducing microaggressions or not so microaggressions that really compel the entire team to take part in that discussion about things that happen day in, day out. There's no other place for. But the nice thing is we're doing those things anyway, so we don't have to, there's no money involved, maybe just like a little bit of reading and forethought, but it really utilizes every member of the team just contributing their own experiences and then trying to figure out what are the structural things that we can do to try to prevent that from happening again, or what are the immediate responses that we should have for this kind of predictable recurrent event, so that every team member has the facility to respond to them in the future.
Yeah, I really love this. Who in the room has gone to the faculty champion training? Has anybody here gone to that? Okay, so a few people in the room. It's actually really excellent if you guys, probably those of you who are on faculty who get these announcements, it's actually worth the half-day training. But I remember at that half-day training, it came up this idea, oh, they should have diversity M&Ms, which sounds really great because you can imagine, you know, you can bring up a case of harassment or something, you can teach people about how to be a good ally, you can teach people at the Title IX office, the care, you know, there's all these things that you can teach people. But as I was talking to Esther about it, it was like, you know, then you name it a diversity M&Ms, right? Who's gonna go, right? The usual players are going to go, as opposed to kind of weaving it into our normal pre-existing structures, which I think is what I was hearing this being. And it's also what I love about this idea is it's so much something that each of us could whether we run a team or are a member of a team, can pitch up to members in our team that is not that scary to think about trying to implement. And then I guess I think about the Bobby Kennedy quote about the little ripples, right? You know, it's like Bobby Kennedy had said something, basically, I'm paraphrasing, but you know, little things that we do create little ripples, and that eventually like creates a real momentum and shifts things. And so what I like about it is that it's something that's operational that people here in the room could potentially think about doing. Yeah. It's a little different than being like, I'm going to deal with salary equity in my department where everybody's, you know, pretty protective about that information, and it might be at the chair's level, right?
Right, totally. Yeah, I think anything like that where it can be built in. And I also think there needs to be, no matter what, I think another thing that we talked about was that this needs to be the responsibility of everybody,
Yeah.
particularly of leadership. So I think often what happens with these diversity, inclusion, and equity offices or roles is that it allows everybody else to shut their brain down about the issue. And so it's like, what do we do to actually make it owned by the people who actually have the power to change things? So incorporating into annual reviews of leadership,
Yes.
things where you just sit down with the dean and there are targets, or at least a general conversation about awareness and moving forward in terms of diversity and equity goals should really be owned by whoever the highest leader is in the room, and then that way it can filter into,
Yes.
faculty meetings and, conference, any convenings, basically.
Yeah.
Where it should be.
And this was happening at Yale, right?
That was so at Yale, they were having a conversation where every chair who met annually with the dean and sort of gave them their departmental report had to actually bring a spreadsheet of their faculty with sort of demographic information and talk about the composition of their team and actually go over the salary is there too, so actually review salary for who's paid what and why for what roles and make sure that there's equity built in there too.
Yeah.
So kind of this planned conversation around diversity and equity annually, which can kind of serve, you want to have some things that are a carrot and a stick, and this is not quite a stick, but at least like this accountability moment where I'm going to have to go into this room and explain why my faculty looks like it does and why it's paid the way it is. And so just these little checks along the way to make sure that equity becomes habit, becomes part of your muscle memory.
Right, and I think most of you know we do something similar at UCSF. So our dean, Talmadge King, has each department kind of report on their diversity metrics, and because of so much of the work that was done in earlier finding out disparities based on salary, I know this because I have to deal with the ones on my department. They'll look at the outliers and ask about high outliers and low outliers, and you have to really explain why this is true. And it becomes accountability, so that the chair meets with the dean and they're both kind of talking about these issues together. Very interesting. And another kind of innovation, which is kind of coming outside of our sector that I was hoping maybe you could tell people about, was Callisto, because I don't know if everybody knows about that.
Yeah. Have you guys heard of Callisto? So Callisto is kind of addressing the issue that sexual assault is almost impossible to report if you are a single and only reporter. And so there's actually statistics on this. If you come forward, it becomes kind of like this he said, she said report, and it's a terrifying process. There's high likelihood of retaliation against the reporter and low likelihood of any positive action. And unfortunately, we know that in many, many cases, sexual assault is a recurrent event. And so we miss the reporting initially, and that person will just go on and continue to demonstrate that behavior. So Callisto is an app that has been launched at university campuses, mostly for undergraduates. And what happens is if you're a victim of sexual assault, you go in and you log down the entire incident. So exactly what happened, dates, times, and all the information you have about the perpetrator, including like their social media accounts, emails, everything that you can put in there. And then nothing happens. It gets locked down. It's completely confidential until there's a second complaint. And so it does matching. And when there's a second complaint against one, it alerts both people, or as many people as reported, links them and offers them a meeting with a legal counselor. And the reporting that goes up is, when you have something to sort of corroborate that this person has done something is very high, and the likelihood the legal counselor will walk them through all their options for taking action, and people are just much more empowered to come forward when they're not alone. And it sort of gets around a lot of these issues that we struggle with when it comes to just reporting. The confidentiality, having somebody sort of outside of your institution that you can trust, and having objective legal counsel, things like that, and also just having the support and validation of somebody else who's been through the same thing. So that started on campuses. They most likely will launch in other settings. We would, obviously all of us in this work would like them to go beyond sexual assault and be able to report sort of broader forms of harassment and aggressions and types of behavior. But all to say that there are really interesting sort of tech innovations that kind of allow us to overcome some of the traditional challenges to reporting. Because right now reporting is a very, I would say, very dicey thing. It's an extremely high-risk activity. If you just read news reports, it's very clear that often it's much more costly to report than to do nothing, even when the harassment is ongoing. And so, that is a point that's just begging for innovation, and I'm excited to see it start to happen. I think it will come, and I think it will come fast and hard because we're so far behind. One of the things we talked about this morning was the National Academies of Sciences, Engineering, and Medicine's report on sexual harassment in academia, where they report that, many interesting things, including that it's worse in medicine for reasons that you can imagine, but also that we've basically made no strides in this problem for many decades. And so, if you had a guess, you would think there would be evolution. There are things where we're just getting better as the human race, right? We're evolving and things must be getting better. There's more women in the workforce. We're all much more woke. We have people that save us, But then there's these areas where this is surprisingly not getting better. In fact, maybe it's getting worse. Airplane travel is like that, right? It should be so much better than it was, but it's not as nice anymore. But sexual harassment is also like that, where you kind of have this gut feeling that things should be getting better, but by all available data, we have really reached stasis. And the depressing thing is that our target right now, I talked about, let's articulate targets. Our target right now is to not get sued. Or at least to make the payouts as minimal as possible. It's a miserably low standard for all of this. And really what we should be moving the target is prevention, right? But we're not anywhere near the prevention work because we just have this absolute downstream metastatic cancer kind of barely keep it alive kind of work that we're doing. And so, it's hard to understand because this is it's such a high cost to institutions, not just the payouts, but what it costs your reputation in your workforce, and the productivity and the ability of people to stay in the game at work. The costs are difficult to measure, but are extremely, extremely high. And just attrition of one faculty member, it costs so much more than their annual salary to replace them in that year. And so, I think it's a huge opportunity for organizations to save money and do better with what they have. So I think all of this is covered.
Yeah, how many people here in the room have heard about that National Academies of Sciences report?
You have to read it. It's really interesting. It's super interesting. There's many aspects to it. But, and there's, you don't have to read all 300 pages. There's some beautiful summaries of the highlights, but you might actually want to read all 300 pages. It's very well done and talks not only about the prevalence of these problems, but also their antecedents, and the downstream impacts, and really captures the cost, and then also has a nice long section about strategies for mitigating it in academia that we really need to do.
Yeah, and so some of the highlights for those of you who don't know about it very much are that there's sexual harassment is highly prevalent in all STEM fields, but worst in medicine. And so they attribute that likely to a lot of the hierarchical structures within medicine, as well as the fact that medicine and these other STEM fields predominantly have males as leaders. And if you have more females as leaders, kind of in more equity, there tends to be less sexual harassment. The other thing is around terminology, right? And that's what Esther was getting at, where Callisto's great because it's trying to make people not feel alone so that they feel more comfortable in reporting. But then there are aspects, right, here in academic medicine, it's scary to think about going forward and saying something about something egregious because you think maybe that's, you're not alone. But there's all these other kind of aspects of harassment that have to do with just kind of putting down people based on their gender, right? And that's stuff that even right now within academic medicine, that's nothing that we would go and report. Right, that's nothing that right now makes it so that you could get somebody removed from their position, but is something that taints the water. And so that was another kind of big take home, is that these kind of things that are happening that aren't really right or equitable really do kind of taint the water, and then that's bad for the health of all of the providers, which then makes it poor for the health of our patients, right? And I guess I know also part of this report is around kind of how it's even worse, let's say, for women of color. And so have you seen, we haven't really talked about this, but about intersectionality, have you seen some interesting work being done in this area anywhere? Any sparks?
It gets harder when you read into intersectionality because we so often just ignore, intersectional effects at all. And I think it's just some of this anxious avoidance and fatigue. I do see more programs, gatherings, initiatives for, say, women of color. If you, first of all, there's been kind of an explosion of bodies out there to support women and to make it easy for them to find networks of other women. I mean, I think PMG, if you don't have this position, there's no position on this group.
It's a Facebook community.
It's a Facebook group. It's like not just any other Facebook group. It's like physician women who are moms, very broadly defined, have come together in this Facebook group, and I think there's like 75,000 of them now, which is crazy. It's bigger than the town I grew up in, just like physician moms. There's lots of information supporting, and there's lots of things that happen in this group because it's so big. It's like a small town, and there's sub-interest groups. But I think overall, it's a place where very busy people who cannot fly to a conference to get support can go on every day and get career advice and camaraderie and support and even job opportunities you see play out there. And I think there are so many venues like that, and now they're starting to get really subspecialized. So there are multiple conferences, some very official, like the AAMC conference that supports diversity and inclusion, to just really these pop-up groups that are specifically conferences for women of color. I think there's like one for, there's like a unicorn conference. I know, I was like, that sounds great, I want to go to it, but it's like, no, it's for Black women. It's not, because they're unicorns in medicine, and I was like, they have like a t-shirt for it. But I think there are more opportunities to get career development support specifically for intersectional groups that have very specific overlapping experiences. I think the challenge there, and I think all of this will play out as we're kind of in this explosion of trying different things. Yeah. The challenge is we, women of all kinds, need the regular stuff too, right. And so, I keep getting asked, do I want to do this career development opportunity for women or this one for minorities? But I also don't want to miss out on the one that that everybody else is getting too. Yep. So it's like I alternate. It's like at some point it feels like in trying to get to these different forms of support, it is adding more of that sort of cultural taxation that we worry about, which is do everything that everybody else does, then get special support for your special needs, And what I would rather see is that the norm is redefined, so that the resources that we get are inclusive of everybody, and you don't have to go on special experiences, even if they're well meant. And I think that's kind of what we need to shoot towards, even if we're creating these little kind of band-aid resources to get people through in the meantime.
Yeah, this is great. I know we've got probably about 20 more minutes. Do folks in the audience have any questions for Dr. Choo?
Silence is good too.
It's like a question in progress, but so as you're discussing these sort of like bands of support, I'm hearing some trends are these amazing gatherings for women or specialty groups are coming together. But doesn't that further segregate or move people away from the possibly leadership positions, and then it's like these isolated pockets of community? And it seems like what we need is to penetrate the like leadership boardrooms and things like that, and have people that maybe don't want to take ownership around these issues take ownership. Because you're talking about like taxation of the individual who's having to advocate for themselves. So I guess I'm just wondering how we get people to care that don't want to care.
Right. That is like the question. So Christina and I work on Times of Healthcare together. I just found more buttons in my pocket.
Oh, awesome.
I have like 3 kids, but I keep on taking them out, and then I find a couple of different pockets, We work on Times of Healthcare together, and there's a lot of different advocacy groups, and they all have different approaches, but Times of Healthcare is really about getting into the room where it happens, looking across stakeholders that have real power to make change, and asking them to come to the the table with us and make major commitments, not just like checkbox things, but major commitments to changing their culture so that it is more inclusive of everyone. So this is the fundamental question: how do we get them to change? And actually, I started engaging organizational psychologists in this work because I actually don't know the answer to it yet, and I think maybe collectively we can come up with it, because we have a whole host of behaviors, particularly in healthcare. And it's like we've gotten people to use checklists and to wash their hands more, and all those. Actually, a lot of that is work by organizational psychologists to figure out what is the messaging and the buy-in. I mean, something that we really worked on with Times Up Healthcare is to try to reiterate over and over again that the case for this is not fairness or being nice or doing the right thing. Like, those are true, but I fundamentally do not believe that that's what changes cultures. I think it has to be about the bottom line, at least in part. So we talk a lot about the financial case for change and the actually the patient outcomes case for change. And if nothing drives, if this doesn't drive change in healthcare, if money and patient outcomes don't drive change, then then I don't know what will. But I certainly don't think just leading with "please be more fair" is I will say everybody nods their heads and said yes, of course, and then nothing changes. So I think really making it about money and clinical outcomes is how we make people care. But I totally agree with you. I think, on the one hand, I think what a wonderful and inspiring thing it is when women gather. Like we've had a couple of these things where we get together in the room and there's just so much camaraderie. And I mean, I actually think if anybody wants to support the patriarchy, like, get in the way of these women's gatherings. Because when women gather, something happens and it's magic. I used to think we should do everything online. Like, there's no reason why. There's nothing that you can't do in a Google Doc. Or Skype, the combination of those two things. But I've completely changed my mind about it in the past year, because with Times Up, not just Times Up Healthcare, but Times Up, the mother organization, which I'm pretty involved with, when we gather across industries, there's real magic. And I think you just see when you're on the ground together how much women have in common in every role, in every industry, and you feel very empowered to rise up together and change. I mean, Times Up started because farm workers reached out to women in Hollywood and said, "You are our sisters, and we see you and we support you." And that was such a moving experience that they started gathering, and now we have this national and actually international organization called Times Up. But I think there is something about gathering, at least while we still experience inequity and discrimination, that is really key. But I do start to feel this fatigue. I mean, I'm on this sort of track where I'm being sort of prepared to be a chair of a department someday. And so I took the chair course, which is mostly guys, but I was like, if I'm going to be a chair and most of the chairs are guys, I got to do what the guys are doing. So I'm doing the chair course. But then I'm also doing the women development programs, because it's different than what it is for the guys. I actually need this extra stuff because the experience of being a female leader is extremely different. In a way that we don't talk about, because we're always like, let's get women in leadership roles and everything will be great. No, it's actually very hard keeping them in leadership roles, because the way that women leaders are treated and talked about is fundamentally different. And I would say the harder you go up in healthcare, the harder it gets. Everyone's great and supportive of you when you're junior faculty. When you are rising, many people feel uncomfortable about that rise, and it gets tougher and the air gets thinner, and there is much less of everything: mentorship, support, even just respect as you rise. And so women use extra things, and you just spend an extra $1,000 on this course and time away from your productivity that moves you towards that role. And then, of course, the whole army of people who are running those experiences and how underpaid they are to do that for their female colleagues and mentees. This is largely really uncompensated work. And so I do think that is problematic. And what I'd love to see is that chairs course that I took really being redesigned to incorporate all the things that not just women need, but minorities of all kinds and all abilities. That would be a wonderful thing to see, and we all go there and get what we need from it using the same amount of resources. It would be an incredible thing. And retrofitting and then applying that concept to everything in healthcare.
And I think times are kind of shifting a little bit. Things are moving. It can feel slow, right? But I definitely know you're right that there's an overrepresentation of women doing this kind of work and minorities, and sometimes women who are minorities, right? And then they're unlikely to get paid as much. But slowly I've been noticing that more people are getting part of their FTE covered, or some little amount of money that's there, or I'm hearing more things from male chairs, like about how you don't have to carry the water, Christina. I can carry that. Like my chair said that to me. You don't always have to be the only one in the room who's saying this stuff. You know, because, well, A, he's going to be listened to differently than I am because he's a white man, but B, because he's my chair, right? And so it sounds different when it comes from him, you know, and how it hits people. And there's a lot more movement in he for she and people who are really trying to push from all angles. So I feel like it's going in the right direction. It's just, I wish we would get there sooner.
Hi. Thanks for your comment about sort of the stagnation of movement towards decreasing harassment. And you mentioned, you know, one of the goals now is not being sued. And something I've noticed time and again, when people start thinking about moving away from being sued by the survivor, they become worried about being sued by the harasser. And anything that you do to put something in place opens you up to a lawsuit by the harasser. And I was just wondering if that's something you've seen and if you have any comments on ways to start thinking differently about that.
Yeah, you're talking about how not only as we try to support survivors, there's kind of this backlash, and it makes it even, that sometimes there's unintended consequences making it even harder to pursue action.
Or that the person accused will threaten to sue if they have anything, you know, any sanctions put on them, even minor ones.
Totally, I know, totally. So it seems to kind of like create this reactionary thing. I mean, I think that is true, and I think that's actually always the case, you know. And if you look across kind of historically movements of whether it's for progress in terms of racial equity or gender equity, there is always this little backlash. It's always kind of like 2 steps forward, 1 step back. And I heard a really lovely talk by a feminist scholar named Paula Giddings, and she was talking about how backlash is a sign of success and should be 100% anticipated. So if you haven't made progress, you will never experience backlash because nobody cares enough. And how psychologically we should be much more prepared for this. And there's apparently a small scholarship out there that could be a lot more. But when you're doing a movement, whether it's at even in a department level or institution level or a broad cultural level, you should build in, at least psychologically, the expectation of backlash because it always happens. And just stay, first of all, prepare people that this will happen, and try to anticipate the forms in which the backlash will take. So people will say we've gone too far, and now innocent men everywhere are going to be in jail and out of a job, homeless, and attacks on our social system. You know, I mean, like these really extreme concerns about this teeny tiny false positive rate. You know, and and try to anticipate all the different forms that it will take, and then build in responses and even just like frameworks for that fear. And I would just say usually the fears are so overblown. I mean, we have statistics on the number of completely unreported sexual response rates of the reporting rates. So it's completely underreported of the teeny tiny percent that go forward. Very few of them ever lead to sort of censure against the assaulter. And then there's this teeny tiny bit that goes to justice, but of those, most of them are definitively with physical evidence positive. And then there's a teeny tiny sliver on top of that teeny tiny sliver that is a false positive rate. I mean, it's like a single digit, and yet people are worried about that. You know what I mean? They're not worried about all of this. They're worried about this tiny little sliver of something up here. And so I think that's where data is our power. We have to constantly put things back into a context that shows how overblown certain fears are. I mean, this whole series of articles, men won't mentor women anymore because they're so afraid of Me Too. It's like, wow, in what way are you mentoring that this is a concern for you? You know, I mean, I think there's kind of like a whole kind of this feels kind of emotional reaction to regular processes coming into play that keep people from really extreme behaviors. So that's what I would say. I think it's something to expect, to respond to provide data to, and really just a symptom of progress, actually.
I have a question regarding the safety rounds. I'm really intrigued on how that works. And is it focused on interactions between patients and providers? Or is it providers, faculty, trainees?
I mean, I have just done it a handful of times and heard of people doing it, but I think it's probably best open-ended. And I really think about, especially with the work of Time's Up, it's focused on the needs of the workforce. But sometimes I feel that I neglect what our patients experience. I think it's really important to realize that an atmosphere that is not safe for employees is also not safe for patients, and I think it's all one and the same thing. The Joint Commission has a lot of, has sentinel events and requirements related to violence and sexual harassment in the workplace setting that's really focused on patient safety. And I actually think that part of the reason I do this work in particular is because I think we forget that we have workplace standards, right? And if you've been through residency, you come out the other end thinking there are no standards, and the sky's the limit, and you can be treated however. And I think, just trying to right that perception and creating basic standards for us in this kind of crazy, extreme setting that we work in is kind of the point of groups like Time's Up. But so I think these conversations are best being completely open-ended, sort of talking about from patients to patients, between staff, on the hierarchy at equal levels, like really keeping them as open-ended as possible so that people can sort of talk about these things, because we know that and one of the reasons that medicine, where there's the highest prevalence of harassment in medicine, is there's just so many potential interactions. There's so the diversity of staff, many supervisors, many different. I mean, the surface area of contact with other humans is just so extremely high. Patients, their families. It's just we're 24/7, so there's no parameters in any direction, and so I think there's just so much potential for harassment, and so I think our conversations also need to be as multidimensional and inclusive, because I think no matter who it's happening between, ultimately the problem is the same, and we need to address it.
Yeah, and that's so tricky. I mean, I know the data around, especially around patients or family members who might harass you as a provider. The data, there are some studies where the data isn't excellent, but it's happening quite a bit. And I imagine, as we've talked about, right, we're in a privileged position as two physicians within the healthcare team, but that there might be the one-to-one that's sitting in the room with a patient, or a nurse's aide who's in a less privileged position and might be more, a victim of that kind of behavior. And then what do you do about it? I think there's often this, what's allowable, what's not allowable, what can the patient say, what can't they say? We don't have a lot of good language for dealing with that, which these kind of opportunities of talking about safety can help the team figure those things out together. Any other questions? Oh, there's some up here.
Thank you so much. I had a question. If anyone is on Twitter, definitely check out Dr. Choo's Twitter persona or truth, but it is wonderful and insightful and incisive. But you've been very public on social media and have been quite an advocate, and I've also noticed have taken so much flack in some cases for having your voice and standing your ground. And I would just like to hear your perspective of what it's like to kind of be in the center of a swirling Twitter war firestorm sometimes, and how you've managed to come out of this so strong and so perseverant.
I appreciate that question. So if you're not on Twitter, so I maintain this active social media account. I started in 2013, first just thinking, oh, I'll do a little medical education. And then it turned into much more of an account for advocacy for a wide range of issues. I do talk a lot about racism and sexism and sort of the traditional structures of healthcare. I also advocate a lot for healthcare access. And I just blow off a lot of steam, which is obvious. When people meet me, they're like, "You're not at all angry the way that I am." So it's a piece of mental health for me. So check it out. Just take it with a grain of salt. But I will say, I think first of all, I'm tremendously privileged to have the sort of the platform that I do. I'd always in my mind thought the really huge accounts were 75,000 followers, and I just crossed that the other day, and you can't tweet to that. Like if you're like, I'm tweeting to 75,000 followers, your brain starts to melt and you feel super self-conscious. So I just think I'm tweeting out to a few friends, and that's kind of like the mental space that you can be in. But I think, I think there's there's power in it, and I think there's also a lot of responsibility there. And I will say, I was already kind of inclined to be pretty self-critical, but Twitter keeps you so humble. I mean, it does not matter how much I've been out there and talking about these issues. Probably once a week I post something that is not inclusive of everybody. And I'll give you an example from literally a week ago. I posted, I said something like, would it be strange if I had a fifth child just to name that him or her Greta? Because I'm really obsessed with that environmental activist, Greta Thunberg. I find her she's my favorite person on the planet, including my family. And somebody commented, thanks for using like a he and her binary pronoun, which was completely valid criticism. And I just sort of tweeted it off thoughtlessly, and where in general, like in other things where I'm like, here I am as a Time's Up member, I'm trying to be much more thoughtful. Now, definitely not a week goes by where there isn't something that I do that is so explicitly exclusive or is really hurtful to people. And I sometimes think, who would I be if I didn't have social media, to keep me honest? I think I would retreat to my safe spaces, and I would be much less aware of the ways that I was just thoughtlessly exclusive, even as I did this work of inclusivity and belonging. And I think I get so much more out of it in that way than I put into it. Really, if you want to know the secret, it's like 10 to 15 minutes of my day, every day, that's it. I mean, I have a cap, and it feels like it's more, but it is really just downtime. Like when I'm in line for the grocery store, I'll do a little bit more. But it's such a minimal input at this point for a lot that, I basically have, 75,000 very critical editors of my daily thoughts, and it's been such a growth experience. And there are lots of times where I'm very uncomfortable, and I have to apologize or admit that I'm wrong or reconsider my framing. But it's just an amazing free service for sort of checking my privilege and my own biases as I do this work. So it's just I don't know where it came from, but it's a real lesson.
Yeah, you also mentioned something during my rounds this morning about the conversations that you have, what you gain from it, and how you kind of saw that some people who are not interfacing on what they might miss. Can you just...
Yeah, it's really interesting. I've had this a lot recently where I'll give a talk or I'll start a conversation in real life about diversity and inclusion, and people who are not on social media, they've actually, so I guess it's kind of like the opposite of the process that I'm talking about. If you never engage or very rarely engage in these conversations, you miss a whole round of, there are waves on social media where we decide that certain language is not appropriate. Or we introduce concepts like, I learned about manterruption and appropriation and this new kind of lexicon for describing biases. I learned all of that on social media. I used the word mantle the other day and somebody had no idea what I was talking about. I was like, you cannot be on social media and in healthcare and not know what a mantle is. And it comes to this point where I feel like, a few cycles in, you decide not to be in there, and you're not aggressively in these conversations and other means. I think you start to sound dated very quickly, especially when you consider social media time, where everything has a lifespan of like 3 days, if that. But it's like I can almost tell within a 5-minute or less conversation whether something is on social media or is not. And that's how powerful I think that education is. I mean, if I'm off for a week, I often will miss things and I'm sad about it. I will miss an entire reference point. So there is kind of, I guess that kind of speaks to the crack cocaine-like addiction of it as well. We're constantly worried to miss out, but I genuinely think there's a real and tough education to be had there. But if you're not having it, you start not being able to kind of keep up with the kids. And I feel like that it hurts everything. It hurts your ability to communicate with a wide range of people, and it affects actually your ability to lead, because I feel like social media is real insight into what people won't say in workplaces. It's readily, what people are thinking about their workplaces is so readily available on social media. I mean, sometimes people will be like, I didn't know that was an issue, and I'm thinking, you know, it was trending. I mean, it was literally like such an issue that across Twitter's 30 million users, it was a visible blip, this issue of whatever it was, pay equity. You know, to have gone through the past month and not know that pay equity is an issue for the last day, it's just like, where have you been? And so, you know, I have these moments where I realize it is increasingly apparent when you are just so clueless on an issue, and social media is a good check about that. You know, just sort of get the temperature of, you know, of an entire community. And I appreciate it's a sample of that community, but I think, you know, it's a sample that is engaged, cares about these issues, and has a language and a framework to talk about it. So, you know, it's probably a pretty good community to be engaged in.
Oh, yes, we. Oh my gosh. Well, it was, we are in a, it was a good end. But it was so wonderful having you here. And let's just give Esther one more.